We'll take questions at the end of the session. Next, I call upon the Chief Instructor herself, Dr. Soumya Narayanan. She's a consultant oculoplastic surgeon at Puttalat Eye Hospital and Dr. Chandrakant Eye Hospital, and also does a good amount of freelancing. She will be talking about mastering lid reconstruction, basics and beyond.
Good morning all. I will be talking about lid reconstruction basics and beyond under these headings. So first about lid defect not involving the margin. So in this case we can do a direct closure without distorting the lid margin after undermining the superficial tissues to avoid undue wound tension. The tension should be directed horizontally by placing vertically oriented incision lines. If that is not possible, we can go for full thickness skin graft or local skin flaps. So this is a case of direct closure. And if there is a fat in the wound site, that means the septum is breached, so we should explore for the LPS injury. The orbital septum should not be sutured back to avoid eyelid retraction from vertical shortening of the sutured orbital septum. So full thickness skin graft is suitable for simple anterior lamellar defects or in use in combination with vascularized posterior lamellar replacement in case of bilamellar defects. So we can take skin from ipsilateral or contralateral eyelid, as Animam told, retroauricular, inner brachial and supraclavicular areas. These are the ideal donors because of the similar color, thickness and texture. So hypertrophic scar is the most common complication and can be reversed by massage, steroid ointment and silicone gel application. So this is a case of full thickness skin graft of the lower lid. So local flaps are superior to skin graft because of the functional and aesthetic outcome, because they have superior color and texture matching, better blood supply and reduced scarring. So we can use random pattern local flaps which derive their blood supply from perforating mucocutaneous blood vessels, or axial pattern local flaps which derive blood supply from a cutaneous artery. So depending on the reposition method, we can use advancement flap, rotation or transposition flaps. So this is a example of VY advancement flap. This is a case of Mustard's cheek rotation flap, and this is a transposition flap where we used for a lateral canthal BCC. So axial pattern flaps can be based on superficial temporal artery, supratrochlear artery or angular artery. And lid margin, lid defects involving the margin are very important because we need a precise approximation of the tarsal margin and the tarsus as such, because that gives the integrity to the lid, and any lid margin irregularity will disturb the ocular surface hemostasis. So for that we need to know about these three landmarks, that the meibomian gland orifice posteriorly, gray line in the middle and lash line anteriorly. So when we have a defect, we should do a full vertical height of the tarsus should be excised in parallel incision and should be sutured. So for the lid margin suturing, we can use three sutures, one through the meibomian gland, second through the gray line and through the lash line, either simple sutures or vertical matrix sutures, and the knot should be kept long and incorporated into the skin sutures. So after the suture of the lid margin should be little everted, and then we have to close the tarsus using a partial thickness sutures, and skin and orbicularis has to be corrected. So these are few examples. So if there is again tension during the direct closure, we can do a lateral canthotomy and cantholysis for an additional 3 to 5 millimeters of medial mobilization. So an incision is put from the lateral canthus horizontally to the lateral orbital rim, and cantholysis performed in a piecemeal manner till we get a desired closure. So Tensel's semicircular flap also will help for a direct closure with the medial mobilization of the lid. So for that we have to put for the lower lid we can put a arching incision line marked beginning at the lateral canthus, going upward and coming inferiorly, and skin flap is dissected thoroughly and undermined. A lateral canthotomy has done and it has displaced nicely for a direct closure. So lateral canthal defects can be corrected using horizontal strips of periosteum or deep temporal fascia attached to the lateral orbital rim and attached to the remaining eyelid margin. A Y-shaped pedicle flap of periosteum can also be used for the lateral canthal posterior lamellae of the upper and lower lid together. So medial canthal defects, we have to attach the tarsal plate to the residual medial canthal tendon or to the periosteum directly, either with a heavy permanent suture, wire or titanium mini plates. and there will be defects involving the lacrimal drainage apparatus that also should be taken care of. So we should suspect a canalicular injury in all cases of medial lid injuries, and probing is diagnostic, and we should suture it as soon as possible, especially within 72 hours. So in this case, we have to first find out the proximal cut end. For that, we can use a fluorescein stained dye and find or air or pigtail probe. So after injecting that, we can see from where it is coming out, and after finding out the proximal cut end, we can dilate the punctum, pass the monocanalicular stenting through the cut ends, and later we have to close the pericanalicular tissue using a 80 vicryl, and the lid defect also should be corrected. So these are few examples. Even though the lesion looks the tear look very small, there can be canalicular defects. So this is the mini monoca usually we use for the monocanalicular defects. So the importance of anatomical, functional and aesthetic restoration is very important for the desired outcome. Thank you.
Thank you, Dr.